Okay, this video is in regards to week 14 of CEP 650, and we're talking about Wilson disease. You can see from the photo in the first slide already that there is a very distinctive symptom, which is that outer ring that is in a very specific color. Um, this is not the only disease that can influence the eyes and create difference in those rings, but the color is relatively unique. So let's start. Um, we can talk about an inherited disorder which causes excessive accumulation of copper in the body. Particularly, you can see the liver, the brain, and the eyes. We can see that symptoms appear between age 6 and 45, but most likely at the age of 13, 14 as a teen. The features of this condition include a combination of liver disease and neurological and psychiatric problems. Why not? Let's have a party, right? Of course not. You can see that it's often fatal if not recognized and treated when symptomatic. The disease may be misdiagnosed if unique symptoms do not appear and more common symptoms do appear. So it's not absolute. You can have the disease and not have the unique symptoms, and then it might be misdiagnosed, and that is lethal. Might be a lethal misdiagnosis. Um, as you can see, it's often or at times misdiagnosed as viral hepatitis and or cirrhosis. Um, Copper is not a bad thing. It's needed in the body. It's needed for a lot of cellular functions, but it is toxic at high levels and when not chaperoned or confined into a molecule or to a certain amount. So you can see that the copper transporting ATPase 2 protein is in particular important for the elimination of excess copper from the body. So this would be a protein that connects to copper and makes sure that it leaves the body or that its amount is regulated. In order to avoid misdiagnosis, we need a very thorough investigation to take place. We need slit lamp examination, so that's basically just a flashlight into your eye that reveals the presence of the rings that we talked about, the Kaiser Fleischer rings. Once again, visit slide 1 if you want to see them. You won't necessarily see them without looking very specifically into the eyes. Blood test for low serum levels of chirolopsamine, which is a major copper carrying protein of the plasma of the blood, and has a role in iron metabolism. Urine analysis for copper. Obviously, a major rule in testing is if you can't see it, you want to see if it's going to appear in plasma or in urine, usually in both. A liver biopsy, and then haplotype analysis, which is a genetic test, or rather a method of testing, not a specific test, to be accurate. Symptoms: yellow skin. Obviously, you have a problem with your liver. That's so jaundice is one of the natural symptoms. Sclera, yellow discoloration of the eyes, mucous membranes, and we can talk also about leg edema. We can talk about abdominal edema. We can talk about the presence of abnormal blood vessels in the esophagus that may lead to bleeding. So if you remember, I believe I taught you several times that if you look at the periodical table and you see those substances that have a high electrical charge, of +2, +3, or -2, -3, high in the numbers, not necessarily the mathematical signs. Those are troublemakers, and we're talking about copper. So we can talk about bruising and prolonged healing or bleeding because it affects the blood tissue, excessive tiredness. It affects oxygen delivery, liver failure. This is, of course, at a different range of severities. And you can see that it tends to be mostly in adolescent females. As you know, in average, female have a lower hemoglobin content than men to start with. Any kind of liver disease, just to differentiate between liver failure and liver disease, not the same thing. A wide range of anemias, so any change to size, shape, quality, content, and count of red blood cells by definition. Hemolysis, so the breakdown of blood or RBCs. Mental confusion, although of course this is not unique, right, to this disease. Rusty brown deposits in the corneas of the eyes, those are the rings that we're talking about. Tremor, involuntary movement. Obviously you have the brain affected, so you can expect several disorders or symptoms regarding the brain, and one of them is problems with movement. Dysphagia, so problems with swallowing. Difficulty speaking to poor articulation. That, of course, is coming from the brain. Lack of coordination, coming from the brain. Spasticity, coming from the muscles. And the accumulation of copper. You are talking about a metal. So if you accumulate, it's definitely going to change the mechanical or biomechanical properties of the area. Dystonic postures, of course, you're becoming weaker, so it's going to affect your posture. Muscle rigidity, same idea. Depression. Depression is almost the natural companion for any disease. Nonetheless, this one. What else? The list goes on. Changes in personality and behavior. Definitely with such a horrible disease, it's going to affect you. We can see that it can affect the monthly cycle in young females. It can either stop it completely, it might not even begin, or it might be irregular. So any kind of changes to the monthly period, miscarriages, infertility, kidney stones, definitely. Just to remind you that kidney stones are actually large compounds of different kinds of materials. It can be magnesium, it can be calcium, and it can be copper. When you have high levels of such a metal in your blood and obviously in your urine, it has to go through the renal system, and that can lead to renal failure or to cell damage, tissue damage in the renal system. Premature arthritis, osteoporosis, so you have an imbalance of calcium in the bones. Obviously, accumulated copper is going to create a different gradient wherever it's going to be, and that includes the bones. You can see osteophytes, meaning that you have an overgrow of bones in certain areas, creating large joints. and then reduce spinal and extremity joint spaces. Obviously, if the bone is overgrowing, it's growing into where the space is supposed to be, right? So that would reduce the space itself. Regarding the genetic information, it's rare, it's inherited. You can see that it has a 1 to 30,000 ratio of prevalence in the, worldwide. It's across all races and ethnicities. And you can see that the ratio for carriers is 1 in 90, meaning that if you put 90 people in a room, you should have one carrier, right? It's autosomal recessive, has nothing to do with the sex chromosomes. It's not X-linked, it's not Y-linked. You need a defective copy from both your mother and father in order to actually have to be symptomatic, right? You have a 25% in every new birth to the same two parents, 25% of being having the disease, being symptomatic, then 50% of being a carrier, and 25% of not being a carrier and not having the disease. What else? Equal chances between sexes to be affected with every birth in the family. By the way, notice that you can find a family, once again, it's 50-50, but you can have a family that has 2 daughters, 2 sons, and only the sons have the disease, or only the daughters. That does not mean that there's a pattern here. It's just unlikely to happen. That's all. In theory, in a classic way, for the same 2 parents to have 2 daughters and 2 sons, in theory you should have 1 son and 1 daughter affected or having the disease. In case of 50-50. Okay. What else? Of course, if you have 1 copy, you are a carrier. I just went over these points. We can see that we have more than 300 mutations to the ATP7B gene that has been identified. Once again, the way we interpret this is that this gene is unstable, and also that we can naturally assume, unless proven otherwise, that there will not be a tight phenotype-genotype relationship, or I should say genotype-phenotype relationship, because there are so many mutations. In addition, the more mutations, the more wide variety of symptoms you can expect, and as you've seen, there's a lot of symptoms to this disease. So those are the principles that I want you to remember and understand, and we're playing with again and again and again. So the gene obviously includes the instructions to create a protein that is a copper transport protein, and when you don't have enough copies, or the copy is dysfunctional, you have a problem, and that causes accumulation of copper. So we can see that the mutations cause the protein to be dysfunctional. So you don't have a copy problem rather than a dysfunctional problem. Then you can see that as of late, and it's truly as of late, another gene has emerged as a possible collaborator. In this case, it's a negative collaboration of nature in nature with the PRNP gene. These two both have something to do with copper transportation and regulation. You see that people with a normal PRNP gene have much lesser severity of symptoms, especially those who are related to the brain, meaning that the PRNP gene affects mainly the brain. It encodes for another copper transport protein in the brain, which can battle some of the symptoms but not all. If it's battling some of the symptoms, obviously it's reducing the severity. We can see that those with a mutation in both genes have worse severity of symptoms, especially in the brain. We can see that in the PRNP gene, the defective gene replaces methionine with valine, and that is enough to create the disease. So we're talking about a whole we're talking about a mutation that causes a change from one amino acid to the other, right? So that would be a change in the reading frame of the ribosome, and it's enough to have a change in one nucleotide to cause that. Then we see three distinctive genetic dynamics result in the majority of cases when we're talking about the gene ATP7B. The first one is the replacement of histidine with glutamine. So instead of having histamine, you have glutamine. Then the replacement of arginine with leucine. So instead of arginine, you have leucine. And then you see a whole deletion of a sequence, which is the promoter region for the gene. The promoter region, to remind you, is in front of the gene, and it's the one that increases the affinity of the ribosome to that gene, which increases the chances of the gene to be expressed. So in this case, it's deleted, and that decreases the chances of that gene to be expressed. Functional and practical implications. Obviously, the inability to transport copper causes its accumulation. Toxic level, as you know from pathophysiology, cause cell injury and death, especially in the brain and liver. It also has many cellular applications, so that might cause abnormal second messenger related processes in the cell. Just to remind you, if you don't mind, a first messenger operates from outside of the cell, a second messenger operates inside of the cell. Treatment, we have chelating agents, medications that bind copper and cause its release in the blood and excretion through urine. Those are the major medication types that you're going to see used. There's two major kinds used right now. Of course, any kind of ability to decrease the intake of copper and accumulation is advised, so that would be environmental factors. Then we can we can make sure that copper is not absorbed into the body by zinc acetate. Liver transplant and severe damage to the liver. Nothing unique here. You have liver damage to the point where you need a new liver donation. And avoiding the following, which has high levels of copper to start with as food: liver, shellfish, mushrooms, nuts, and chocolate. Ooh, that hurts. No chocolate cake for you. Current treatment, you can see the amount of symptoms. I think it's kind of a given that you're going to need more than one caregiver. So obviously, you're going to need a specialized caregiver for each one of your symptoms. So I think that's kind of really, that's why I wrote it that way instead of writing each and every one of the caregivers. Obviously, you have a multifactorial disease here with multi symptoms, and you're going to need to be treated accordingly. Future possible treatment. Um, Genetic testing for this disease has advanced to detecting where the disease is possible already as a fetus, which is unique. Not This is not the only disease that we're able to do it at a fetus level, but it's definitely unlikely. Or as a newborn. With newborns, it's easier, obviously, but still, the earlier you can diagnose someone, the better. So these abilities are getting better, so we can treat people earlier. Um, but this is not widely performed. And notice that I said or known. So some physicians don't even know yet about the ability to conduct this as a fetus or as a newly born baby. This is truly the latest information. It was published in 2017, so it's more than possible that the word is not out there yet in the medical field. Um, we can talk about future treatment as hepatocytes transplantation, so specific to the liver tissue, gene therapy. Uh, Both have been tested and shown to work in animal models, uh, um, uh, almost 100% in rats. And even then, it really depends on what rat model you work with. Medications are slowly improving their effectiveness, but there's no change to the medications themselves. Exercising them, um, by definition, advised, but must be conducted with extreme caution. Um, we're talking more about focusing on mobility and stamina than anything else. Their intolerance to exercise is high and can be life threatening, so we definitely need to keep it short and mild. That's it for week 14. If you have questions, please send them to me. I'd love to answer them. Thanks. Bye.